So like Dr. Hahn said, I'm Taylor Hughes. I'm one of the third-year urology residents, and I'm going to be presenting on a tale of two tumors. Essentially, we're going to be taking a path through two children being treated for Wilms tumor and looking at the Children's Oncology Group and the International Society of Pediatric Oncology guidelines for their management. A little bit of background on Wilms tumor or nephroblastoma just to start. It's the most common renal malignancy in children and accounts for about 6 to 7% of all pediatric cancers. It's thought to arise from embryonal nephrogenic rests, essentially the abnormal persistence of embryonal tissue that can develop mutations in tumor suppressor genes like Wilms tumor 1 and develop malignant potential. It classically has a triphasic histology with stromal, epithelial, and blastemal components. The only reason I'm mentioning that is because that becomes more relevant when we're talking about some of the staging and risk stratification. It has a mean age of diagnosis of 4 years old, and classically thought of in terms of the rules of 10. So 10% have unfavorable pathology, closer to actually 6 to 7% in reality. 10% are bilateral, 10% present with some form of vascular invasion, and about 10% have pulmonary mets at time of diagnosis. So for the rest of the presentation, we're going to be taking the perspective of the families of these two children. So these are identical 4-year-old girls who had their parent or their pediatrician feel a palpable abdominal mass. The only difference between these two children is that one lives in San Francisco and one arbitrarily lives in London. Okay, and so once the pediatrician has felt this mass, they get an abdominal ultrasound, and it shows this. This is a 7-centimeter renal tumor that the radiologist says highly suspicious for Wilms, and that's basically the information we have. For argument's sake, they also got axial imaging and they had no evidence of metastatic disease. It gets a little bit more complicated in metastatic cases, so we're going to assume that this is just a solitary tumor. So looking at the treatment guidelines for the Children's Oncology Group and the International Society of Pediatric Oncology, at the risk of butchering the French title for it, they're essentially the two groups that form the guidelines for the management of children's cancers. The Children's Oncology Group is the group that pertains primarily to the US and Canada, formed only about 20 years ago from combining the 4 NCI-funded groups that were studying pediatric cancers, including the National Wilms Tumor Study Group. And so there was a series of trials from 1974 to 2003 out of the National Wilms Tumor Study Group that essentially forms the basis of the guidelines. With the International Society of Pediatric Oncology, this group was started in Europe, but essentially creates the guidelines that the majority of the rest of the world follows outside of the United States. And they have individual branches for essentially every other continent. And they similarly had a series of trials from the 1970s on to early 2000s that form the basis of their guidelines. So starting with our child being treated here in the United States, if you're talking to her family, the first thing you're going to be talking to her family about is that the standard of care is upfront surgery. So when we're treating kids with Wilms tumor in the United States, typically our first line of therapy is radical nephrectomy with node sampling. There's no recommended or kind of guideline number of nodes specifically, though there is some evidence that there's a higher rate of identifying positive nodes if you sample more than 10. The goal or the philosophy of the Children's Oncology Group guidelines is essentially to establish pathology of the complete specimen prior to doing staging. Because a solid tumor, Wilms tumor tends to be very heterogeneous, and Wilms tumors have very variable pathology with different risk stratifications based on what they see. The idea is that you get the whole tumor in its kind of unaltered form in order to get the most accurate information about what this disease process looks like and how do we risk stratify this child for future treatment. There are some contraindications to upfront nephrectomy, essentially some exceptions to the guidelines. These typically are if there's a tumor thrombus above the hepatic vein, if there's contiguous spread where removal of additional structures would be needed, if there's pulmonary compromise from the metastatic burden, or kind of the more nebulous unacceptable risk based on the surgeon or anesthesiologist's perspective. I also want to touch briefly on the role of biopsy in inoperable tumors. So within the Children's Oncology Group guidelines, if a biopsy is done, that child is automatically a stage 3 because it's considered to be residual tumor within the abdominal cavity, regardless of whether that biopsy is taken at the time of nephrectomy or preoperatively. So looking a little bit about the pros and cons of the COG approach, the primary one is that you're avoiding any kind of therapy before you know what you're treating. So you're avoiding chemotherapy for a potentially benign disease. Looking at the SIOP trials, they did a retrospective review of all of the kids that they treated and then saw that they actually ultimately gave neoadjuvant chemotherapy to benign disease about 1.5% of the time. Things like nephrogenic rest, also for potentially for different malignancies. So there was about a 5% rate of treating a non-Wilms tumor, presuming that it was Wilms upfront. And so you can have different malignancies like neuroblastoma or clear cell sarcoma of the kidney that may have warranted either no treatment or a much more aggressive treatment upfront. And so you can lead to delays in care. And again, speaking the histologic examination of the complete specimen is thought to kind of give the most accurate representation of the disease process for risk stratification. The major con for this approach for upfront surgery is that there is a very high risk of tumor spillage compared to kids who get preoperative chemo. So the risk of tumor spillage is actually about 20% with upfront nephrectomy. Only about half of those represented actual intraoperative tumor rupture. The other half of those were situations like breaks in protocol where they did biopsies where they weren't supposed to, and that was called tumor spillage. But either way, there's a very high rate compared to kids who get preoperative chemotherapy of there being residual tumor in the abdomen and upstaging and worse mortality. The other con is that if there are larger tumors that you're trying to treat with upfront surgery, they may be less amenable to nephron-sparing surgery or partial nephrectomy. Within the COG guidelines, partial nephrectomy is still not considered standard of care. It really is only spared for certain situations like horseshoe kidneys, bilateral tumors, solitary kidneys, things like that, that are higher risk for developing CKD. But as more and more surgeons are attempting partial nephrectomies and really trying to spare as many nephrons for these kids as possible, that may be a con or a downside of taking this approach. So I wanted to put the staging up here for the Children's Oncology group, just because at this point in her treatment, we've done surgery, we've gotten the specimen out. Not going to go through all the specifics, but really stage 1 and 2 essentially mean that you, to the best of your knowledge, removed all residual tumor, and 3 through 5 means that we know that there's some amount of residual tumor in the abdomen, 5 being bilateral involvement at diagnosis, and then each individual tumor is stage 1 through 4. Really the only kind of important difference between this and the SIOP guidelines are that biopsy in the COG staging protocol puts you at a stage 3, whereas within the Society, the International Society of Pediatric Oncology, it actually only puts you at a stage 2. I also put this risk stratification by anaplasia graph up here, not to go through the specifics of chemotherapy agents, radiation doses, that is much too far into the weeds, but rather to talk about the philosophy of risk stratification, because that is really the main difference between the two approaches. So with the Children's Oncology group, it's obviously risk stratified by stage, but really by the presence or absence and extent of anaplasia that we see in the tumor. So favorable histology obviously is lower risk stratification, and then the presence of focal or diffuse anaplasia. Also within the COG guidelines, they have some role for molecular markers within the risk stratification. So looking at things like loss of heterozygosity at 1P and 16Q that are also factored into how we risk stratify kids. We're going to be turning our attention towards the other child who lives in Europe. If you're seeing her parents, you're going to be talking to her about the ultrasound. You see a 7-centimeter mass. We don't know definitively what it is, but we think it's Wilms tumor. We're going to start 4 weeks of chemotherapy no matter what. So that's going to be with vincristine and dactomycin, and then repeat cross-sectional imaging, essentially to see the degree of tumor change after that chemotherapy. Then you would be proceeding with a radical nephrectomy and lymph node sampling, where they recommend at least 7 lymph nodes in the sample. And they actually account for the possibility of partial nephrectomy in their guidelines, but only in very specific situations, such as infants or unilateral tumors with a very small tumor volume after chemotherapy. Again, looking at the pros and cons of this approach, there are reduced rates of tumor rupture and intraoperative spillage, as I mentioned previously. And really the philosophy of this approach is that you can gain additional prognostic information based on the tumor's response to the chemotherapy. So it's really using the chemotherapy as another method of risk stratifying these children. It may also be more feasible in low resource settings. So there are several papers out there out of India and Pakistan, kind of comparing children who were treated under these two different approaches. And it showed that because there isn't always access to really kind of advanced forms of imaging like MRI to characterize more complex tumors or renal vein invasion, it's more feasible and more realistic to give chemotherapy up front, and then can use things like ultrasound that are more accessible in order to image the tumor going forward and have potentially a simpler surgery. The major con of taking this approach is that it's thought that it's more difficult to interpret the histology post-chemotherapy with the degree of necrosis. And also you have no tissue diagnosis prior to initiating chemotherapy. And like I mentioned in the SIOP trial that was done 1993 to 2001, they showed that they actually were giving chemotherapy. Of all the kids they gave chemotherapy for, 5% of them did not have Wilms tumor. At the staging for the International Society of Pediatric Oncology for Wilms tumor here, really no substantial differences from the COG protocol, but other than the difference in staging if a biopsy is done that I mentioned previously. And so this is where they philosophically are different approaches. The risk stratification under this, under their guidelines is actually by histologic classification. So rather than just relying on the presence or absence of anaplasia, they really are looking at the degree of tumor necrosis and the residual viable tumor as the means of risk stratification. So that combined with looking at the components of what the tumor is made of. So that triphasic histology that I had mentioned, whether the tumor was predominantly epithelial, predominantly stromal, or predominantly blastomal, that essentially is what they use in order to risk stratify children into different groups. So taking a look at these two children, this is essentially what their treatment plan would look like. If you were talking to a parent and say, hey, I have these two treatment options, these two philosophies, under the COG guidelines, the child would be getting upfront radical nephrectomy, which would potentially carry the risk of up to a 20% risk of tumor spillage and upstaging. They'd be getting adjuvant chemotherapy that would last anywhere from 19 to 36 weeks, plus or minus anthracyclines like doxorubicin, which carry the risks of cardiotoxicity, and then plus or minus flank radiation. In Europe, they would be giving neoadjuvant chemotherapy for 4 weeks, radical nephrectomy with a lower risk of tumor spillage, adjuvant chemotherapy for a longer period of time, 27 to 34 weeks, and then a slightly higher degree of flank radiation. The important part is, does any of this matter? Is one approach better? Are there any difference in outcomes? Parents do not care about whether the histology is epithelial or stromal. They care about how their child's going to do both in the short and the long term. So looking at the late outcomes, there was a meta-analysis published earlier this year in the European Journal of Pediatric Surgery that essentially looked at long-term outcomes of pediatric renal tumor survivors treated under the two different protocols. So the mean length of follow-up for those papers was about 17 years. So you can imagine the mean patient, if they were diagnosed at 4, that these stats represent someone in their early 20s. So under the COG protocol in the US, there's actually a 23% rate of hypertension compared to only 10% in Europe and others treated under the SIOP protocol. I don't know what degree of that is confounded by the United States lifestyle and other kind of confounding factors, but it could be theorized that it's because you are, potentially having a more complex surgery, having fewer surgeries that are amenable to partial nephrectomy. Similar rates of CKD, but under the SIOP protocol, there's a much higher rate of secondary malignancies. So about 7% as opposed to only 1%. That is theorized to be because there are higher doses of radiation used in SIOP protocols than within the COG protocols, but there's still a lot more investigation that's needing to look into that. And overall, the big picture is that kids with Wilms tumor do really well. Their overall survival is greater than 90%, in some cases greater than 95%, really regardless of which approach you take. There are still some ongoing challenges in Wilms tumor treatment. The primary one being that with these two separate philosophies of treatment and risk stratification, there's no universal standard. So what's a stage 2 in the United States is not a stage 2 in Europe. What is considered a high-risk kid here may be intermediate risk in Europe. So comparing data internationally is really challenging because you aren't judging on the same system. There are also some special patient populations that don't do as well and don't necessarily fit into these guidelines we talked about, primarily anaplastic histology. So overall, Wilms tumor survival is greater than 90%, but for kids who have anaplastic histology, it's still somewhere between 30 to 60%. And if you have an anaplastic Wilms tumor that recurs, that overall survival drops to less than 10%. So there's still a subset of these kids that we don't have a great handle on how to treat, and being able to collaborate internationally and having kind of a uniform way of evaluating these kids would probably go a long way in terms of helping advance care for them. Similarly for bilateral tumors and recurrent Wilms tumor. Bilateral tumors, I didn't go into it in detail here, but it's actually one of the areas where the guidelines align fairly well. And so that is proposed as a potential area where we can do kind of a proof of concept of if we look at combining cohorts of kids with bilateral tumors treated under the COG and SIOP protocols, we can essentially get larger patient populations and see how they compare. And finally, there are obviously ongoing challenges with survivorship. With any cancer that affects primarily children and that has really high survival rates, the attention then turns towards their quality of life, of how are we affecting children later in life who are going to have to live with these consequences for many years. So obviously they're struggling with hypertension, with CKD, with secondary malignancies and effects of chemotherapy like cardiotoxicity. And so I know we are going to be hearing from Dr. Nicholas Cost from Children's Hospital of Colorado talking more on survivorship from pediatric tumor. So I'm not going to go into that too much, but I think in terms of overall Wilms tumor treatment, we've come a long way in the last 50 years, but there are still some subsets that need a lot more intervention. And I think kind of knowing that there are these two standards of care out there and knowing which is appropriate for which child will go a long way. And I'm happy to take any questions.
I have a question that happened from something that happened to me a few years ago here on the adult side. Is we had a Stanford undergrad who had a big renal mass, and I can't remember why we were thinking it might be Wilms, but we were, and so we biopsied it, and then they said, oh well, now she needs all these 20 other treatments that she wouldn't have needed. I'm like, why is that? What's the data that supports that a needle biopsy makes you the same as somebody whose tumor explodes in the abdomen?
I don't actually know the specific data. Dr. Hahn, were you gonna join in there?
Not insignificant increased risk of recurrence if you don't give radiation. If you do a biopsy, it's like it's a single digit percentage, but it's elevated. And anytime you have a recurrent Wilms tumor, it's really bad.
Right, but is it the same as stage 3 exploded tumor when you operate on them?
I don't think so, but it's not insignificant. So
Dr. Skinner, that would be one of the differences in the two staging systems, is that under the COG protocol, biopsy would be stage 3, similar to if the tumor ruptured in the abdomen, whereas in SIOP, that is a lower stage considered than tumor rupture.
I'll do it in France. That's
one difference also is that it's whole abdominal radiation versus flank radiation. So the radiation field is different.
But if I biopsy somebody through the flank, there's no reason to radiate their whole abdomen, right?
So the outcomes between the two protocols,
Mhm.
there was like a 5x difference in the likelihood of proceeding between the US way versus the SIOP way, right? Like it was like 3 to 7% versus like 20%
Mhm.
proceeding. But then you still end up with 90% overall survival. Doesn't that make an argument that proceeding is actually not that damning if the survival outcome is the same, as long as they're getting adjuvant afterwards?
I think the radiation, so they do more radiation. So their staging is different, and so their regimen is different. So you would get increased radiation.
But actually the SIOP, where you have less tumor spill, they're giving higher doses of radiation, it sounded like.
Yeah,
It's pretty confusing.
it is. Yes.
But you did a great job, Taylor,
Oh,
explaining
thank
it.
you.
Just some comments. So one thing about decision making on management of pediatric renal tumors, there's a lot of thought that goes into it, and a lot of clinical factors, most notably age, that will determine it. So if you have someone that's outside the age range, let's say greater than 10, then you're thinking about other things, like renal cell or something like that. And also, Wilms tumor tends to metastasize in a certain way, typically lung and liver. And if you see something else, then you think of something else too. So, the SIOP, you might think like, why are they just giving chemo to every kid who has a renal tumor? But there's a lot of thought, and I think it goes to show their low percentage of giving chemo to kids without Wilms, which is 5%, which I think is pretty low. So, yeah.
I have a question on it seems like in the adult world, the thought on tumor seeding from a renal mass biopsy is changing a little bit, and that it's less of a risk because we do it better now. Is that right? I haven't read too much about this, so please correct me if I'm wrong, but do you think that could also be applicable to the data on biopsy for Wilms tumor? Like with better methods, there's just less risk of seeding?
So it doesn't matter. I don't know about these new techniques we're talking about, but in terms of like the biopsy, so whether it's you do a true cut needle biopsy through the flank or anything like that, you would still be considered upstage. So I don't think it'll that would change anything with regards to that.
I also think it's interesting that they treat it the same way if you do an intraoperative biopsy. If you already have essentially the abdomen or the flank open and you take a sample and I presume send it for frozen to see what the path is, that is also considered essentially seeding the abdomen entirely.
Yeah, to add to that, so even if you do a piecemeal resection, that's still upstaging to stage 3, even though like it didn't touch anything else. Like you cut it in half while you're taking it out, it's still considered it. I don't know why exactly, but it is. You'd presumably think it'd be okay, but that's the case.
I mean, I think it's such a rare tumor that we just don't have the numbers to prove some of the things that Dr. Skinner's talking about. Things are changing slowly. I think in the future we may be doing some partial nephrectomies. The only problem with Wilms is that by the time they present, they took over the whole kidney. So to have a small tumor that's amenable to a partial, it's pretty rare. I've only had one in my career, and I did a lap nephrectomy or lap partial on it. But I was following this kid for reflux, and then on the ultrasound, she had a little new growth that was pretty peripheral and exophytic. So I took it out, and I was surprised that it came back as Wilms. But usually by the time you diagnose them, they're just taking over the whole kidney. So it's the lap partial may never come down the pipeline. Just a couple other things with Wilms that to add in your 10% just for the in-service and tests. 10% come with syndromic kids. Remember your Wagger, your BWS, your dentist trash, Perlman syndrome, those usually pop up in the in services and tests.
A good point was raised before about biopsy techniques. And in fact, when you go back and look historically, when biopsies were done, it was usually through big chevron incisions. You were opening up the abdomen, and it was a big true cut that went in there. And that's more likely to spill intra-abdominally. Now, where you have small biopsy guns and you can do it through the flank, I think there's probably less likelihood of seeding there. And as modern technology catches up in pediatric urology, there might be some sea of change in the future with some biopsies being done. Because I think in the European fashion, if you do treat up front, I think you can shrink down and have a lot more children available for partial nephrectomies. Whereas if you just go in trying to do a primary resection, they do present with very large masses, and it's almost impossible to find the case that is accessible to a partial at that point.
Like even in my lifetime, when I started as an attending, we were still doing contralateral exploration for Wilms, and that was part of the NWITS protocol. We thought that our fingers were better than the CT scans, and maybe they were at some point, like 100 years ago. But CTs are, as it became, better and better, then that part of the Wilms protocol went away.
What is the sort of division of labor between urology and pediatric surgery when it comes to these large renal masses?
So very political and turf dependent. So back where I did my fellowship in Colorado, Dr. Koss, who you'll be hearing from soon, he took over maybe 80% of the renal masses. And I think the biggest reason is because these kids all need chemotherapy, and so you need to be able to do ports. And so in the vast majority of children's hospitals, that's being done by pediatric surgeons. And so they already have the kind of the connection with oncology, where they refer all their patients who need ports. And so they already have a relationship with them. And so majority of places, it's pediatric surgery that's doing them, because they can do the lines if needed. So very few places where urology is involved because of that reason.
A kidney, all of a sudden, that one a urologist involved.
I think that's also the reason why in North America, radical nephrectomy is the standard of care, and it's a big part of it is because Wilms tumor tends to present with such a huge tumor, you can't possibly do a partial. But there have been some case reports, case series where you do partial nephrectomy after neoadjuvant chemotherapy, and they do quite well. I think those limited studies show that you probably have similar outcomes as a radical nephrectomy, but it's still, COG has been doing studies for so long that it's difficult to argue that to go towards the direction of partial nephrectomy, since their outcomes are so good. And although the CKD risk is about 15%, the risk of ESRD is actually like 0.2%. So it's really low still. So. Thank you, Dr. Hughes.
Thank you.